Hi, good afternoon, everybody. This is Katie. Oh, there's my screen. So we're just going to take another minute or two to get started. Just let people dial in. We may change the agenda up a little bit today. I'm just taking a look to see right now. We may start with our speaker today, which is Andrew Solomon from the Northeast Telehealth Resource Center. Hopefully you can all see his presentation, the front page of that on your screen. If not, please send me a private message and we will make sure that you can. Until then, let's just hold on a few more minutes. Thank you. All right, I think we'll get started, guys. Again, this is Katie Cook from Adirondack Health Institute. Welcome to the October Telehealth Learning Collaborative. I can't believe it's already October and that the telemedicine conference is in about 2.5 weeks. I know a lot of you on this call will be attending, which is really exciting. So to kick things off, per the agenda, I know we typically start with updates from our state agency friends. Rayanne has not dialed in yet, so I'm going to skip her for now and we'll circle back to those updates. I do know for a fact that no one from OMH has any updates at this time, so we can skip that part. And we'll move on to our speaker today, which is Andrew Solomon. Andrew is the project manager for the Northeast Telehealth Resource Center. The Northeast Telehealth Resource Center basically covers all of New England and the Northeast. There's 12 resource centers in the country, 2 national and 10 regional, which he'll speak to. And Andrew is a fantastic resource above and beyond the North Country Telehealth Partnership for anything that you really need to get your program up and running, have questions about legislation, regulations, both at state and national level there. It's a fantastic resource, and I probably call Andrew once a week. So I figured he would be a great presenter today. So I'm going to turn it over to Andrew to give us a brief review of the telehealth landscape.
Thank you, Katie. Thank you so much for the kind words. Thrilled to be here today, although I do join most of the meetings. Thrilled to present. As Katie mentioned, my name is Andrew Solomon. I'm the project manager for the Northeast Telehealth Resource Center. And I'm going to share a little bit about what the telehealth resource centers do and then dig into the telehealth landscape, really focusing on policy. and happy to take questions as we go through this, or we can have questions and discussion afterwards. So as Katie mentioned, the Telehealth Resource Centers, there are 14 of us. We are federally funded through the Office for the Advancement of Telehealth, which is part of the Federal Office of Rural Health Policy and part of the Health Resources and Services Administration. We have 12 regional centers, and together we cover all 50 states. And we also have 2 national centers, as Katie mentioned. One is a Center for Connected Health Policy based in California, and they track all of the existing and pending legislation and regulation related to telehealth. And then we also have a Technology Assessment Center based in Alaska. And they're sort of like a Consumer Reports for telehealth technology. They buy all the different toys and equipment and compare those and help us sort of track and assess the technology landscape. The Northeast Telehealth Resource Center, I'm based at a public health nonprofit called MCD Public Health in Augusta, Maine. We provide a variety of different grant-funded public health programs. Because we don't provide clinical services, we partner on this grant with the University of Vermont Medical Center, and they're our clinical champions. I think Judy Amore is on the call today. She's our TA specialist and coordinator at UVM, and they're an excellent resource. They've been involved in telemedicine for 20 plus years. We also have a researcher at the Regional Medical Center at Lubec, which is an FQHC in Down East Maine, and he's also been involved in telehealth for about 20 years, and an excellent resource for us to track all of the peer-reviewed journal articles and other resources. So if you're interested in any of the literature, we have almost 40 different bibliographies that we collate and update, compiling peer-reviewed literature, resources, and really about anything and everything that's been published. As Katie mentioned, we cover all of the Northeast, which includes New England, New York, and Northern New Jersey. We share New Jersey with our colleagues at the Mid-Atlantic TRC. We provide services. Our grant funding is primarily directed to rural providers, rural organizations, but we work with really about anybody and everybody who reaches out. It could be private practitioners, FQHCs, health systems, hospitals, really anybody and everybody, any way that we can sort of help embrace and grow the telehealth industry. Our primary focus is providing technical assistance, anything from understanding reimbursement policies to equipment selection, really the A to Z of program development. We have a variety of different educational materials. We have tools and templates, things such as job descriptions if you're looking to hire a telehealth director or manager. We have a number of sample consent forms and tools like that. Happy to share any of that. We also have a monthly newsletter, and we really try and support a collaborative environment for telehealth growth. A few of the resources we have on our website, which is netrc.org, we have a telehealth resource library that you can search over 2,400 publicly accessible journal articles. And we're working on updating that, which I'm really excited about, a new website coming in the next couple of months, and we'll be sharing more about that. We also just recently launched a tool called Telehealth Connect, which we're using to map telehealth across the country, really focused on hub and spoke telehealth networks. And we just released a beta version. It'll be posted on our website soon. When you get these slides, you can also click the live link to check it out now. We have been testing it out in the Northeast for a couple of years, and we've now rolled it out nationally with the idea that we can track telehealth organizations and providers across the country. There's also a couple map layers that you can experiment with, like a layer that will help you identify Medicare eligibility for telehealth reimbursement. We also host a telehealth leadership forum, which is a monthly call the first Wednesday of every month at 2 o'clock, similar to the North Country New York Learning Collaborative. We explore implementation challenges and really try and foster collaborative problem solving around telehealth. We also host a regional telehealth conference in the spring. We had one in May in Massachusetts, and we're just planning our next conference probably in June of 2017, possibly in Portland, Maine, but we're still working to finalize the location. So we'll be sending out more information related to that. And if you're interested in that, I'd encourage you to sign up for our newsletter. You can either scan the QR code that's in these slides, or you can sign up at netrc.org. And we're also available to create a variety of different personalized toolkits and find any resources that we can that might be helpful. So I want to just dig into the telehealth policy landscape a little bit. What have we been seeing and where are we at? Before we do that, I think it's important to sort of reflect on what's happening, what is the current state of telehealth utilization. We know that policy can still be a barrier, and it is a little tricky. But even given that environment, there's still a lot of exciting things happening. So from the HIMSS analytics study for 2017, they found out of the respondents to their survey, 71% of healthcare providers are using telehealth. And that's up from 54% in 2014. So there is a lot of exciting things happening and certainly a lot of growth in the last couple of years, and I think we'll continue to see that. The HIMSS analytics study found that most of the telehealth utilization is through the hub and spoke model, which may not be surprising. I also really like this article from mHealth Intelligence in 2016. In the Northeast, telehealth gets creative with good results. And I think creative is really the key word in this article, and I love that they use that. We see a variety of different models implemented throughout the region, from primary care to telepsychiatry, diabetic retinopathy screening, teledermatology, e-consults, really about anything and everything. And I like the idea of getting creative to increase access to healthcare services. But at the same time, many of these programs have to get creative with sustainability, since reimbursement is not always straightforward. So how can we increase access while also creating programs that can be sustainable, and where is our ROI? And that might require a little bit of creativity. This probably isn't surprising to many of you, but in April, the Government Accountability Office came out with a report that said telehealth troubles tied to reimbursement barriers. And they found that less than 1% of Medicare beneficiaries used telehealth between 2014 and 2016. And perhaps not surprising, they found that reimbursement was one of the major barriers. About a year before that, the American Hospital Association also came out and said limited coverage and geographic restrictions pose a major barrier to telehealth adoption. And I'm sure many of you are familiar with the Medicare requirements that have been in place since 2001 that require the patient to be located at a rural healthcare facility, which is great for our rural partners, but it is a challenge for our urban partners who want to implement comprehensive telehealth programs, but reimbursement may only be available for rural partners. When this policy came out in 2001, the CBO estimated that telehealth would cost $150 million in the first 5 years. But through 2015, the Center for Telehealth and eHealth Law estimated that Medicare had only spent $57 million. So the utilization was not nearly as extensive as the Congressional Budget Office initially thought it might be. We have seen increases though. In 2016, it was reported that payments for telehealth has increased by 28%. Nearly $28.7 million paid for Medicare telehealth to almost 500,000 claims, although we know that's still a very, very small percentage of the overall Medicare budget. I think it's less than 0.001%. So we are seeing growth, but it is limited. Many national companies have come out to say that CMS really needs to waive these restrictions and embrace broader reimbursement policies. That ranges from new demonstration programs to expanding remote patient monitoring programs with new CPT codes. There's a lot of interest in store and forward and expanding coverage for Medicare Advantage plans. But one of the challenges is that CMS can't change the Medicare fee-for-service program without Congress changing the Social Security Act. The current regulations are written into law, so CMS is restricted to the rule definition until Congress changes that. There has been some movement. There have been a number of bills introduced this session. I want to say 6 or 7 that would change Medicare reimbursement in a variety of ways. One that's gained a lot of attention is the Chronic Care Act, which recently passed the Senate and has been moved on to the House. The Chronic Care Act waives some coverage for Medicare Advantage plans and ACOs. It also expands telestroke coverage and in-home services for end-stage renal disease. But it is a bit selective, so it wouldn't totally remove the rule requirements. There's a number of other bills that do some similar things. The CONNECT Act has also gained some attention. It focuses on expanding mental health coverage through telehealth, also a focus on Medicare Advantage and ACOs. Many of us are familiar with the telehealth parity laws, and New York is notable for passing one a couple of years ago. I believe it's now 33 states and Washington, D.C. that have passed some form of telehealth parity, although these laws vary quite considerably. Some might only include certain modalities like live video. They might exclude remote patient monitoring or store and forward services. They might require an in-person equivalent. So for example, if the service is not already covered to the patient's home, it may not necessarily be covered by telehealth to the patient's home. That might be considered a new modality, if you will. And some states have even experienced where insurers will interpret the language as being for certain vendors only. So if you're not working through a certain vendor, that service may not be covered. And then of course there's the issue with Medicare or with eligibility payment. So payment parity. So whether or not the law only covers coverage and you only have to cover telehealth services, or does it cover payment parity? So does payment have to be the same rate as in-person care? And we're familiar with the law that was introduced in New York that would require payment parity. New York law doesn't currently have that. As I understand it, that law is still in committee, so it hasn't made much progress yet. A few states have introduced laws that do require payment parity. Some states have actually specifically excluded payment parity because they see it as an opportunity for cost savings and they expect reimbursement to be less than in-person care. And then when we look at Medicaid, all but 2 states have some kind of Medicaid telehealth reimbursement. Massachusetts and Rhode Island are the 2 states that really don't have a policy yet. And we're very familiar with the New York Medicaid rules, which are some of the most progressive as they are written currently in our region. Vermont and Maine are probably the most progressive. Vermont's notable because they've recently passed a law that requires coverage of telehealth services outside of the facility. So anywhere the patient is located, including their home, Medicare will have to cover for telehealth. That hasn't really been rolled out yet, but we're excited to see how that continues. Most notably for New York, you may have seen 2 bills that were passed this fall that will expand or should expand Medicaid coverage in New York to adult care facilities and schools and child care centers. So those were just recently added to public health law. As I understand it, the way the law is structured, that will apply to Medicaid reimbursement, but these changes don't apply to the section that require private payer coverage. And then some other policy considerations. I don't think New York has really had a conversation about this yet, but the Interstate Medical Licensure Compact has been gaining a lot of attention. Maine and New Hampshire are notable for implementing it in our region. This is sort of like the Nurses Compact, but it's not reciprocity. It still requires a physician to apply in each state, but they essentially can fill out one application and send it into all of the compact states. Where for the Nurses Compact, if you hold a license in the compact state, you can practice in any state that's part of the compact. It's a little different for the physician, but this has certainly gained a lot of attention in the telehealth community, and we continue to see more states join. And then the last slide, I thought this was notable. Just recently, the VA introduced a new rule that would allow their VA doctors to see patients regardless of where they're located. As I understand it, currently the patient needs to be in a VA facility to be seen, but with this new policy, the patient could be at home or any other location to be seen by a VA provider. So the VA is really a leader in telehealth and has taken some really interesting steps to expand access. And I'm sure Katie will send these slides around. These are just a few of the websites you may or may not be familiar with already, including the North Country Partnership website, the Northeast Telehealth Resource Center website, the Center for Connected Health Policy, and others. And this is certainly just the tip of the iceberg. Some of the things that we look at, including reimbursements, licensing issues, malpractice, internet prescribing regulations, what defines a physician-patient relationship, can you prescribe controlled substances, all those different issues that we have to consider for telehealth program development. And finally, our contact information, my contact information, and Danielle Lauder, our program director. And Katie, with that is all the slides I have.
Thank you, Andrew. I don't have any questions. I'm getting a bit of an echo, Andrew, from your line, I think. I apologize. But there are no questions that came through, and I don't see any hands raised, so we will continue moving through the agenda. I don't have anybody from any of the respective agencies on the line, so we'll bypass any updates from DOH, OMH, or OASIS today. One thing that I wanted to go over was, since we last met, there was a second regulatory modernization initiative meeting. And that was on September 27th, and it was in Albany and also in Buffalo. And just a few key updates from that. Most importantly, I think, was from Jonathan Vick, who is the Division of Health Plan Contracting and Oversight. What they have done is issued a memorandum indicating that new telehealth services may be offered by Medicaid managed care plans and reimbursed by DOH. How this will work is through federal regulation now allowing the use of cost-effective services and innovation. These managed care plans can offer their members services that were not previously included. And these cost-effective alternatives are referred to as in lieu of services, or ILS for short. The implementation of this was set for October 1st. DOH will be releasing their ILS guidance and ILS review form later this month. Telehealth delivery not currently covered by Medicaid managed care plans may now be reimbursed through the ILS approval process. So what these plans need to do is submit a telehealth innovation plan to DOH along with a telehealth specific ILS request form within 60 days of the release of the guidance that I just mentioned. What they're looking for are submissions that demonstrate potential meaningful improvements in quality, access, outcomes, and cost effectiveness. Plans that do receive DOH approval will earn 5 bonus points towards their annual QI award and an additional point if their services seek to improve outcomes for women with high-risk pregnancies and children in their first 1,000 days of life. So a good example request of a plan would be submitting to include the patient's home as an eligible site. Those services are not part of the current mainstream benefit package. So be on the lookout for those telehealth innovation plans to come through, and hopefully we see some plans that are approved and expansion of telehealth services. So that was exciting. Lastly, there was a lot of discussion about several things. Ronald Bass did speak a great deal about the current and future Medicaid update. Right now, the holdup seems to be with the fees that Medicaid intends to pay for remote patient monitoring and store and forward technologies. And I did just see that Ray Ann hopped on the line. So Ray Ann, if you could pop in your audio pin and certainly speak to the RMI work group initiative meeting on the 27th, we would love to hear from you. There was also significant discussion about allowing telehealth in the patient's home. There was discussion about provider shortages, lack of adequate broadband access, providers being unclear on what telehealth services are reimbursable or even permissible, and then, successfully billing for those reimbursable services. So Rayanne, if you're on, maybe you could speak a little bit about the work that was done on the 27th. Just one second, I'm just checking our questions. You should be off of mute. Let me just do that, Rayanne, real quick. There we go.
Hi there.
Hi.
So thanks. I'm sorry for joining late. We're on another call just before this meeting that went over. Yeah, so I just caught the last part of what Katie was mentioning, but yeah, the RMI, the second work group meeting was, I thought, a very productive meeting, and that we were able to continue the discussion on the barriers that were mentioned in the first meeting. We're now at the point where we are working internally at the department to summarize those comments and the stakeholder feedback and make some recommendations and even propose some changes to the statutory language and have the various agencies that were involved take into account the feedback in either the development of new regulations or update of existing regulations. So all of that work, I think, will take some time, but and again, I think so many different issues were touched on that we certainly aren't able to make changes to all of those pieces all at once, but to the extent that we can tie changes to the upcoming legislative session and the budgetary process in the spring, we're trying really to do that based on the feedback that we receive from stakeholders. And then again, I heard you mention Ron Bass and the work the Medicaid office. It was work that was occurring, outside of the RMI process, but they do continue to work on the updated billing guidance that will spell out how to get reimbursement for the newer modalities of telehealth that were not previously paid for under the Medicaid program. So specific guidance around store and forward and remote patient monitoring will be available hopefully very soon once they have firmed up what the rates will look like.
Excellent. I do have a question here from Cynthia Gordon. So Cynthia, if you put in your audio pin, you're unmuted.
I didn't, hello?
Yes, hi.
I didn't have a question. I must have clicked on a button I shouldn't have. My apologies.
Oh. No worries.
My apologies. Mute me again, please.
Okay, all right, yeah, so thank you, Rayanne, for that update. Yeah, some of the issues I had mentioned very briefly. There was also a lot of talk about payment parity, and it started, I think, a fantastic dialogue to really get to the heart of that issue. But like you said, Rayanne, that is a contractual issue with the payer and the provider, and it's certainly bigger than any of us. So, hopefully that will become a reality someday, but there's a lot of work that has to go into that.
Mm-hmm.
So that being said, I don't believe there's any updates from OMH or OASAS at this time. There is a question, Rayanne, really quickly. It just popped up. How do we learn more about RMI and that work group and Medicaid info that you are speaking to? Is there a website?
Yes, if you go to the Department of Health website there and you just type in regulatory modernization into the search, it will bring up the page that provides the agendas and the, not necessarily meeting minutes, but the archived webcasts of all of the various RMI groups that are happening this fall. So telehealth is just one of, I want to say, 7 or 8 different topics that are being addressed through this process. So the archived webcasts are available. They're full day meetings, so they're kind of lengthy to jump through, but there's also a function within the archived webcast itself where you can type in, if you're looking for, a specific topic, you can type that in and it will jump to the point in the video where those words were being used, or if you wanted to see what a particular organization or person was saying about a certain topic, you could type that into the search of the webcast as well to kind of speed through and get to the parts that you want to review.
Yeah, and I can send out with the meeting notes the link to the archived webcasts so that anybody on this call can go back and check those out.
I should also mention too that the email address is still active. So there's a regulatory modernization at health.ny.gov. That email address is being used for folks to RSVP to meetings, but also for us to collect additional feedback. So we still welcome feedback. If you watch the archived webcast and you want to weigh in, as a provider on any of the issues that were discussed, or even raise a new issue, you're certainly welcome to do that. We don't have a firm deadline for receiving that feedback, but obviously the sooner the better, because we're trying to really wrap things up in the month of November and get the recommendations written and forwarded in advance to the commissioner and upward. So the sooner we get that, the better.
Excellent. Yes. Thank you. So moving on, just a few updates from the North Country Telehealth Partnership. First and foremost, the North Country Telemedicine Conference is coming up in 2.5 weeks. I have 1 spot left, so obviously this conference will sell out. It actually did sell out, but I had to refund somebody's ticket, so now there's 1 spot open. So if anyone on this call was planning on going, please go register today before that spot sells out. If you need the link again, email me privately and I will send it to you. Moving on, I came across several funding opportunities that I wanted to pass on to the group because the language indicates that telehealth programs or telehealth initiatives, equipment, could certainly be addressed by these. So the first one is the what's the name of this organization? The Robert Wood Johnson Foundation. They have this program called Pioneering Ideas. I will be sending out the links to this as well as the next funding opportunity. So throughout the year, this foundation welcomes pioneering ideas, brief proposals that can really create opportunities to explore, look into the future, and put health first. And what they're looking for are pioneering ideas that challenge assumptions or long-held cultural practices, taking existing ideas and giving them a new spin, offering a new perspective on a long-running, perplexing problem, applying cutting-edge ideas from other fields to health, or exploring the potential for emerging trends to impact the ability of your organization to build a culture of health. The proposal is, I want to say it's like 6 pages long. It's not exhaustive the way a grants.gov application is, but they really just give out awards for innovative ideas. So I'm going to send out the link to that. The other one, most of you probably saw the email from the Office of Rural Health. The Federal Office of Rural Health Policy announced the release of a funding opportunity for the Rural Healthcare Services Outreach Program. And the goal of that program is to support the expansion of healthcare service delivery to rural populations by encouraging a consortium of health providers to innovatively address their community's health concerns. So the applications for this are due December 6th, so it's a very fast turnaround time, but it's a very competitive award. There are 25 awardees for the 2018 to 2021 project period and approximately $5 million allocated for this. So I will be sending out the link to the RFA on that so that everybody can take a look. Again, you've probably already seen that. And then last but not least, if anybody on this call has ideas for future speakers or topics you think that we should be addressing, please let us know. We always try to keep it fun, innovative, inspirational, getting folks from all different facets of healthcare, sharing their experiences and the work that they're doing. So we welcome ideas. And that is all that I have. I know that Bob Hunt from Fort Drum didn't have any updates. Corey, do you have any updates for the group?
I don't, actually.
Okay, excellent.
Yep. Just one other funding opportunity. I'll send this to you so you can share it with everybody. There is also the Rural Health Network Development Planning Grant that's forecasted right now to be released due January 3rd. So it's not out yet, but we've seen a number of organizations leverage that to develop telehealth networks. So I can share that with you as well to pass along.
Okay, yeah, send that my way and I'll include it in the meeting notes. Thank you. All right, that concludes October's Telehealth Learning Collaborative. Again, if anybody has any questions, concerns, thoughts, ideas for us, please email myself or Bob Hunt, both of us together, and we will continue doing the best that we can to get all the up-to-date information out there for you. So thank you all, and I hope to see most of you at the upcoming conference on November 2nd. Have a great day, guys.